Thank you, and thanks to the organizing committee to invite me such a beautiful city. The topic is infection prophylaxis for disease donor organ transplantation Indian approach. I will cover my topic under these headings. The thing is why we need it. Because the solid organ recipients, they are high risk for developing infections, and anti-infective chemoprophylaxis is a time-tested strategy to prevent opportunistic infections in these patients. But the problem is we have a very short time for screening disease organs donors, and it is challenging in these patients. So the prophylaxis is same in the form of pre, peri and post-transplant prophylaxis. But is any major difference from live related donors if the donation is living related? The answer is no. And the pre-transplant prophylaxis, nothing. It is only in the form of vaccinations. What we should do in every patient on dialysis in the form of hepatitis B, influenza, pneumococcal, live related like varicella, 8 weeks prior to transplant. But if they are not vaccinated at the time of the deceased donor organ transplantation, you can take these patients for transplant. Now, what peri-transplant prophylaxis you will give? Is it required? On which therapy, antibacterial and antifungal? The surgical site infection is one of the earliest infections after solid organ transplantation, and it varies from 3 to 53% depending upon which organ you are transplanting. Highest incidence is in small bowel transplant surgery, followed by liver and pancreas transplant surgeries. The first dose should be administered within 60 minutes. First generation cephalosporins, ideally up to 24 to 48 hours, but in intestine transplant, it is minimum 72 hours. Now, does these patients need antifungal peri-transplant prophylaxis also? Very few data available. What is available in mainly lung, liver and pancreas transplantation, and definite evidence is in the lung transplant. Now, post-transplant prophylaxis, you will want to target the bacteria, virus, fungus, PCP. The type of prophylaxis is universal prophylaxis. You give the trimethoprim, sulfamethoxazole to every patient. Preemptive is you periodic monitoring using sensitive assay and start therapy if assay is positive. And hybrid approach is some period of prophylaxis, subsequent monitoring the CMV. The comes with which we usually use in every patient. If you don't give the prophylaxis, trimethoprim and sulfamethoxazole, there is 15% chances of PCP, and if you give it, it is just 3 to 5%. And it covers so many organisms like pneumocystis, nocardia, listeria, pneumococcus, and other bacterial infections. Duration of treatment will depend upon the organ you have transplanted. 6 months after kidney, pancreas and live recipients, lifelong for lung recipients, and at least 1 year in heart transplant. And as per KDIGO guidelines, 6 months after renal transplantation, and at least 6 weeks during and after treatment of the acute rejections. Now comes to the India is an endemic country for tuberculosis. So what should be our approach for disease donor for latent tuberculosis infections? You should careful history should be taken. Disease donor with known or suspected active TB should not be accepted. And if TB is found in transplanted organs, the recipient should be initiated on full anti-tubercular treatment. Live donors with active TB should not be accepted without adequate treatment, and the lungs from donor with significant residual damage from prior TB should not be used for donation. Should we screen the donors for latent TB infections, even this disease? The developed country guidelines, they should say yes, they should be screened, but over guidelines say that do not screen, and even over revised national tuberculosis program says does not recommend universal screening of latent tuberculosis infection. And this is the latest guidelines which are published in 2023. They says this is not applicable in deceased donors. You don't have a time to screen them. But if the living donor has a contact or past history of inadequate treated TB, they screen them with IGRA or versus tuberculin test. What about in transplant candidates? Developed countries, they say screening should be done. In developing countries, they don't recommend, because the sensitivity and specificity and standardization of these tests varies, and screening tests, they have problems. So routine prophylaxis for latent tuberculosis infection is not practiced in South Asia because of lack of good assays, high prevalence of resistance, and India contributes to more than 70% of the global resistant TB cases. If you start giving prophylaxis, then you will create a more problem. But from the developed countries, there is a data which shows decreased post-trans tuberculosis with latent tuberculosis bacterial infections. Few data from India and Pakistan also that it decreased the developing post-transplant TB, but overall mortality and substantial risk of liver damage was high. And what does the KDIGO says, and what does over revised national tuberculosis guidelines says? In TB endemic regions like India, screening strategies or universal therapy for latent TB may not prevent post-transplant TB because there is an ongoing exposure in this country. So if you give, there is a high rate of positivity and resistance to first-line anti-tubercular drugs. So you can try 6 to 9 months of INH, rifampicin for 4 months, INH and rifampicin weekly for 3 months. To come to the hybrid approach in the form of cytomegalovirus, the thing is donor positive with depleting agent if you have used dose 6 months, donor positive without depleting agents 3 to 6 months, recipient positive with depleting induction 3 to 6 months, without is 3 months, and if both are negative, you can try oral famciclovir 500 milligram for 3 to 4 months. The KDIGO recommends the same, but the prophylaxis is more in kidney, liver, pancreas, and intestinal recipients, and it is more in lung recipients, at least 12 months in the lung transplant patients. Which approach is better, preemptive versus the prophylactic? In this meta-analysis, the effectiveness was equal, but the patient with universal prophylaxis, they have reduced graft rejection, reduced incidence of PTLD and post-transplant opportunistic infections. And this paper shows that valganciclovir prophylaxis was associated with a lower CMV infection and more protective than the preemptive approach. Does duration of CMV prophylaxis have impact on incidence of disease? Definitely. If D positive or negative, these 200 days therapies has less incidence of CMV infection, which is 16.1% versus 36.8%. And this is a new drug, letermovir, and it shows that 480 milligram once daily dose is equally effective but with less side effects. Herpes simplex viral infection only if they don't receive ganciclovir or valganciclovir. You can use acyclovir, valacyclovir for 4 weeks donation. Hepatitis B virus pre-transplant antiviral agent should be continued after transplantation, tenofovir or entecavir lifelong. And again, the targeted antifungal prophylaxis in liver, pancreas, intestine organ, in kidney only topical antifungals, while in various agents they have been used in all other transplant for depend upon in which endemic area the patient is residing. Usually they give fluconazole minimum for 4 weeks. And this is for kidney. So summary organ-wise, so you give antibacterial 24 to 48 hours, 3 to 6 months of CMV. If they didn't receive the CMV, SCV 4 weeks, PCP 3 to 6 months, and topical antifungal. If you give kidney and pancreas, then you give the fluconazole for 4 weeks and antiparasitic infection also in the form of ivermectin 2 doses 2 weeks apart. And in liver, the same thing, the antifungal sometimes depend upon the which species in which endemic area the patient is staying, you give the antifungal prophylaxis. Rest all of the prophylaxis are same. In heart, there is more chances of toxoplasmosis, so you minimum give Sapron for 6 months to 1 year in these patients. And in lung transplant, chances of fungal infection is more, so you give PCP at least for 12 months and antifungal from 6 to 12 months. And intestinal transplant, the same thing is PCP for 12 months and a minimum 4 weeks of antifungal therapy is given. Thank you very much.